Very good. Let's finalize our two-day meeting with some novel aspects of what we are trying to do, or where is the future going, apart from improving our ability to perform the bone marrow transplant for most aggressive patients, or most aggressive disease in our myelofibrosis patients. So let's talk about novel agents and combinations in myelofibrosis. Traditionally, how do you talk, or what do you think when you are trying to optimize the therapy? You would like to add something to a therapy that works, right? And you would like to add a therapy that on its own has a track record of a success. That would be logical. And this is a selection I try to combine here, what I have found in terms of combinations based on a backbone of having a JAK2 inhibitor as the primary active agent, where other agents that possibly may have activity, other investigational agents or commercially available agents, are being tested, actually. These are clinical studies underway, or some of them already finished. So what is the goal here, right? You're going to improve the result you already have, make it better, or bring something else that would make this more comprehensive, like anemia improvement or bone marrow improvement. But the bottom line is you should not interfere with the underlying activity of that single one agent, and it has to be safe not to compromise the activity of a JAK inhibitor in this particular case. And unfortunately, we have seen a number of studies where partner agent has interfered with what one would expect from a JAK2 inhibitor on its own, because it was unsafe. So this is a summary of combinations that were presented at ASH. In blue is ruxolitinib, a backbone. In the red color are all the commercially available medications that were combined with ruxolitinib, and in green are two investigational agents. And it was a rather somber meeting for the combination folks, because in yellow, the circled ones are the only ones that showed some real promise. And that real is a questionable one. For today, I selected to present you results on combination of interferon with ruxolitinib, pegylated interferon in PV or early myelofibrosis, because we are talking about myelofibrosis, and not to really dwell into the MPN/MDS where Videsa was combined with ruxolitinib. So other studies did not really show activity, and some of these were already mentioned in the past. Dr. Mesa told us about pomalidomide combination, danazol combination, and I will tell you that others, without showing you data, did not really work out at all. And the studies were stopped. All these studies were stopped, except the one in yellow. So let's see a little bit about combination of interferon and the JAK2 inhibitor ruxolitinib, and that is ongoing study, and there's a very early preliminary results from Denmark. So why would one combine the two together? Well, we suspect for good reasons, and that was explained earlier on, that the JAK inhibitors work through anti-proliferative and anti-inflammatory effects. So inflammation is a part of the disease biology, and that is very well managed by the JAK inhibitors, and the side effects that are provided to a patient through use of interferon that we know of can be also controlled by the improvement of with the JAK inhibitor. So having here two medications that may overlap in activities and the one improving tolerability of the other makes sense for one to combine those things together. So these are the study designs. So, and here there are some issues that I will highlight, because the patient selection or how the things were done are open to interpretation sometimes, and it's not quite clear what happened. You see, the PV or hyperproliferative primary myelofibrosis or post-PV or ET myelofibrosis patients were eligible with evidence of active disease, which was open to interpretation by the treating doctor, or absence of serious comorbidities, again, without further identification of what it might be. Two different interferons were employed, which is in a light blue box. It is Pegasus or PEG interferon with a good dose of ruxolitinib. The endpoints are listed in the lower part, but basically looking at all aspects of benefits that we know, CBC, spleen, and symptoms. In addition, the attractive part of combination is perhaps further improvement in the bone marrow, as well as in the JAK2 allele burden decrease. And here we have some important information about the patient selection. So we had, at the beginning, as you can see, about 2/3 of patients with PV, and about 1/3 of the patients with myelofibrosis, primary or secondary. That's all good. The number of years from the diagnosis is long. However, you can also see that the number of patients, about 90% of them were treated already in the past with interferon. And at the time of enrollment, about 60% of them were on that interferon that is counted as a prior therapy. So in fact, what happened here is that the ruxolitinib in these patients were add-on, rather than that the therapy was combined from the beginning of the efforts in this clinical study. In other words, the complexity of the patient characteristics influence what we see in a study. Patients were already on interferon in many cases, as you can see. So what happened next is analysis of efficacy here, and what is presented here is in dark blue is basically the number of the patients in each group, the total group, all diagnoses, and then by the group types. And in light blue are a number of patients that have apparently responded by the clinical hematological response criteria utilized as it described in the bottom of the slide. Now, we know already that ruxolitinib on its own has activity in PV, and 15 out of 20 polycythemia vera patients in the combination study apparently responded. So one would always ask a question, is it because of one or the other agent, or is it because of the two? And how do you dissect the benefit when it appears to be similar to what each of the agents would be doing? And there are fewer responders, obviously, in primary myelofibrosis, only 2 out of 7, which is not actually very good, because with myelofibrosis, ruxolitinib does better than 2 out of 7. But the numbers are very small, and the study is underway. Now, the high expectations of the biological overlap between the two is, in fact, as we all know, the primary driver behind the combination. And therefore, immediately after having the clinical hematological responses, we were presented, and I'm presenting to you, the JAK2 allele burden in these patients. And there was a decrease from a median of about 57% to, after 3 months, of 37%, and then leveling off at 6 months, about 35%. So these are individual patients, and these are the bars here showing you that decrease. It's up to our interpretation, and we'll conclude a little later whether this is significant or not, but this is actually what is happening right now, the real data as the trial is underway. Now, symptom burden was decreased significantly over these months, as you would expect. And the next question was the safety. In these trials, the median follow-up was only 6 months, and 10% already stopped. This is a 10% dropout rate within 6 months, which you would probably expect with interferon within a year. Is this more or less? It's hard to say. The reasons for dropout are listed here. These are adverse events, and the number of serious adverse events in the lower part. Non-hematological side effects resemble what you usually see with interferon alone. Arthralgias, nausea, you have some infections, but usually what we see on this list would be attributable to interferon alone. So the conclusion from the investigators were that this is highly efficacious combination in these patient populations, and very well tolerated, and you see that the interpretation of the results by the investigator is very, very positive. One may look in the detail and ask many questions, and certainly my impression is that there is much more work to be done to understand whether there is any, in fact, synergism between the two, and whether we would, over time, expect some better results on the allele burden, for example, or tolerability of the interferon, where the dropout rate is already 10% at 6 months. What is the other alternative way to improve the outcome is to find the novel agents. And apart from adding to ruxolitinib, other studies underway are with the novel agents, and selection of them is here. I'm sure that there are others. I missed some, perhaps, but this is what I could find. These are all single-agent phase 1-2 studies, most of them phase 2s, hardly any phase 1, in myelofibrosis, and most of the time in patients that failed ruxolitinib. The most attractive ones are the two. One is the telomerase inhibitor Imetelstat. Unfortunately, we do not really have new results for quite some time now, because the large 200-patient randomized study of doses of Imetelstat is underway in myelofibrosis. What this medication does in this cartoon is inhibiting the enzyme telomerase that maintains the ends of the chromosomes that are being lost as the replication happens. If that is inhibited, then the DNA loss continues to accumulate, and patients' cells die from that DNA loss. So that's would be underlying mechanism, hypothetically what you would expect in a patient. The results of that pilot study that led to current 200-patient randomized study around the globe was published by Dr. Teferi last year. Not to go in much detail, but it is IV medications given every 3 weeks, and the results were very nice. There were a number of patients, as you can see here, that had a CR or PR or clinical improvement, about a third of the patients, which particularly having a CR and PR is unusual in myelofibrosis, with nice pictures in the publications of improvement in a bone marrow with resolution of fibrosis that would accompany a patient's complete response. What, on the other hand, this drug does is provides a significant myelosuppression, and that is outlined in the upper side of the slides, with a number of patients having a grade 3 and 4 myelosuppression, and many of them had the myelosuppressions for more than a month, with complications that come with a lack of a blood cell count, as listed in the lower part of the study. So median duration of therapy overall was only 8.6 months. So there was a small group of patients that had extraordinarily good response, but overall experience was not that good. So does the Imetelstat work through the mechanism that is hypothesized? A lot of text on this slide, because there was in fact, editorial written in New England Journal of Medicine on that question. Are the results compatible with its mechanism of action? And it seems, which is the summary in the lower part of the slides, that there is really no evidence that there was anything to do with the telomerase or telomerase inhibition in these patients, as it was postulated at the beginning, and it might be just that this is myelosuppressive medication, and that's what it does to patients, and no more. The other medication of interest is PRM-151, a recombinant form of pentraxin-2. What is pentraxin-2 or PTX2? As it's listed here, is endogenous regulator of tissue repair. It's produced as a protein, all right, in the liver, and the schematic on this slide would tell us what it would be doing in a normal person, inhibiting formation of fibrocytes that provide the scar tissue in normal people, and it would be also decrease the pro-inflammatory changes within the macrophage lineage that we know happen in the myelofibrosis. So that is the underlying hypothesis of its use in myelofibrosis, with evidence that in patients, the endogenous PTX levels are actually reduced, which would suggest that the PTX in patients with myelofibrosis are, that PTX is used in the bone marrow to counteract the malignant transformation of fibrocytes that differentiate from monocytes, as it was recently published. So to guide you through this slide, first we measure the PTX levels in the blood of patients versus normal healthy volunteers, and then correlate the levels with the degree of fibrosis in the bone marrow, and basically more fibrosis you have, the lower the levels are. There is clinical evidence of activity of PRM-151 as presented at ASH last year, which led to a much larger phase 2 open-label study that is accruing across the United States and Europe. In the pilot study in 27 patients, these were the improvements. Particularly interesting clinical benefit was the improvement of red blood cells and platelets that followed the improvement in bone marrow fibrosis. That was actually seen in about 40% of the patients. These benefits were long-term benefit in those patients that responded, and the ongoing study, in fact, is looking at the activity over a number of months. This is a 9-month study. So what else can be done? This is traditional look at the approach to hematological therapies. You would add something to active drug, you would combine novel or already therapeutically proven drug together, or you would add novel agents that have some underlying hypothesis behind and test them. Now, one approach is to combine 3 drugs. That is not often done, but it is being done in some solid tumors in particular, not much in the hematology. So if 2 are potentially good, 2 novel agents, maybe we should combine 3, right? The disease is heterogeneous, as we learn. It is not usually one target or one pathway. There are multiple others. That's why we do 2 medication combinations. Maybe there is a reason to do 3. And there is actually a study in Europe where the 3 are combined. And these are the 3, ruxolitinib, PIM inhibitor, and CDK inhibitor all together, with a logical explanation why would that work. Now, we'll see what happens in the clinic, but hypothetically, that makes sense. There are preclinical models that actually prove the point that the 3 together should be working, and we'll see in the near future whether in clinic the 3 are tolerable, the safety first, and whether the activity actually adds up. The other way is to understand why medications do not work. And we know why in most of the patients, JAK inhibitors stop working at least. And although this is a worthy slide, the point that I'd like to make, it is not because there are associated acquisitions of secondary mutations in the JAK2. We don't have evidence that in patients there are new mutations in the JAK2 that prevent current JAK inhibitors to work. They are not specific for the JAK2 V6 or 7F anyway. It is because of what we say heterodimerization of the JAK family members. This is in a lower right side of the slide, where the cells are somehow protected from the present JAK2 inhibitor in the environment, and they thrive and continue to grow. And so you would then think that perhaps a different JAK2 inhibitor attaching to the JAK enzyme would perhaps work, and this is outlined on this cartoon, where we have here family members, JAK1 and TYK2, helping JAK2 V617F being protected from the JAK2 inhibitor here in the red dot, and the cells start to signal through JAK-STAT pathway, while perhaps what we call type 2 JAK2 inhibitor, which binds to a different part and binds to active as well as dormant JAK2, prevents this from happening, and these cells die off. So this is a development of novel approach to targeting JAK2 enzyme, and the medication has a CHZ868 name for now that has been published in Cancer Cell some time ago, and we'll see whether this ends up in a clinic. There are a lot of preclinical results on the activity of medications. Again, that was published last year in Cancer Cell. This is just a summary, not to go in detail, that it works in mouse model really well. So the characteristics of these medications are that it should be working in models where the regular JAK2 inhibitor, ruxolitinib, or any other that we mentioned today, does not work, and therefore the clinical efficacy would be enhanced, and the loss of response would be eliminated in a way. So with that, I would conclude my discussion.